Hi everyone. Um, this is the last part of the revision video, and I'll start by questions and answers on the arteries. Of course, first of all, you might be asked about the layers of a blood vessel, whether it's an artery or a vein. So the innermost layer or the inner endothelium is called tunica intima. The middle layer, which is the tunica media, that's made of smooth muscle fibers, is called the tunica media, and then the the outermost layer, sorry, is the tunica adventitia, and it's also formed of connective tissue. So we have the innermost one, tunica intima, the middle one, tunica media, and the outermost one, the tunica adventitia. The innermost one and the outermost one is or are made of connective tissue, whereas the middle one is made of smooth muscle fibers. Which of these layers allows an artery, for example, to contract and relax? It is the tunica media because it is made of muscular tissue. I might also ask about which layer of these three layers will allow an arteriole to control the blood flow to the tissue. It would be, again, the tunica media or the middle layer. Which blood vessels control blood flow to the organs or to the cells? They are, again, the arterioles. And the arterioles are the smallest blood vessels in the arterial part of the circulation, and they lie just before the capillaries. On the other hand, the tunica intima and the tunica adventitia are the two layers that provide elasticity to the wall of the arterioles. Why? This is because inside the tunica intima and inside the tunica adventitia, we have an elastic lamina or an elastic layer. So which layers provide elasticity to the walls of the arteries or to the walls of the veins? They are the tunica intima and the tunica adventitia. But of course, the arteries are more elastic than the veins. The arteries are more elastic than the veins because they contain more elastic fibers than the veins. In general, another question, which has a thicker wall, the artery or a vein of the same size? Of course, it's the artery. Why? It's because of the tunica media. An artery has a thicker, smooth muscle layer than a vein. Of course, if we compare those two arteries, which of them is normal and which of them is atherosclerotic? Of course, the uppermost one is normal. There are no deposits inside the or on top of the inner endothelium, and the lumen of the artery is normal. It's patent, it's open, whereas the lowermost one shows an atheromatous plaque. What is an atheromatous plaque? It is a deposit on the inner wall or on the inner endothelium of the artery. And that deposit mainly contains cholesterol, which is a fatty substance present in the plasma of the blood. And when the levels of cholesterol in blood increase, they deposit in between the inner endothelium and the tunica media together with blood platelets, and they form they convert the inner endothelium into a swollen area that is lined or covered by rough surfaces that result in clotting of blood. Of course, atheromatous plaques are dangerous because, as you might be asked to justify why an atheroma or an atheromatous plaque is serious or dangerous, this is because, number one, it makes the lumen of the artery narrower, and at the same time, it is a trigger for the formation of blood clots that might partially or completely close the lumen of the artery and therefore deprive the organ of its blood supply and therefore deprive the organ of oxygen and nutrients. Of course, I mean the organ that is supplied by the arteriole. You might be asked to justify or to describe the importance of the elasticity of the arteries. First of all, elasticity of the arteries is due to the presence of elastic lamina in the tunica intima and in the tunica adventitia. Furthermore, elasticity of the arteries is more than elasticity of the veins because of a more developed elastic lamina. They are more rich, the arteries are more rich in elastic fibers than the veins. Furthermore, the importance of elasticity during systolic pressure is that it allows the artery to stretch to accommodate the extra volume of blood that will be pumped by the ventricle. Whereas during diastole, the elasticity of the artery will be important because it will allow elastic recoil of the artery or returning of the artery to its original position. So during systole, elasticity allows the artery to expand enough to accommodate all the pumped volume of blood. And this is important because it prevents excessive elevation of the systolic blood pressure. During diastole, it allows elastic recoil and therefore it prevents a severe drop in the diastolic blood pressure. Now, what is the blood pressure? The blood pressure is the pressure exerted by the blood on the inner walls of the blood vessel. Usually, when we ask about blood pressure, we mean arterial blood pressure, and therefore it would be convenient to say the pressure exerted by the blood on the inner walls of the artery. Usually, we measure the blood pressure in the aorta close to the heart because it is the largest blood vessel that whose pressure represents the pressure in the left ventricle. This would be the most ideal place to measure the systemic blood pressure. Since I'm talking about the aorta, then I'm talking about the systemic blood pressure. But of course, there is a problem with measuring the pressure in the aorta. What is it? It is that the aorta is inaccessible. We cannot reach the aorta. So when we measure the blood pressure using the sphygmomanometer, we use which artery? We use the brachial artery, the artery that is present in the upper arm. Why? Because the brachial artery is an extension of one of the direct branches of the aorta, which is the subclavian artery. You needn't know subclavian artery. You needn't know the name. Now, what is the pulse pressure? Of course, you know the systolic pressure and the diastolic pressure. Of course, you have to know the definition. The definition of the systolic pressure, it's the maximum pressure in the aorta during left ventricular systole. And you have to say during left ventricular systole, and it would be great if you mentioned the value. Whereas the diastolic pressure is the minimum pressure obtained during diastole, and it would be great to mention the value, which is around 80 millimeters mercury. The difference between the systolic and the diastolic pressure is the definition and the numerical value of the pulse pressure. So if I ever ask about the definition of pulse pressure, I don't want you to explain how are we going to measure the pulse pressure, but I'm waiting for the definition and the numerical value of the pulse pressure. Of course, the pulse pressure will be diminished in case of diminished volume of blood circulating in the blood after bleeding, which we call hypovolemia, and it would be increased in case of aortic incompetence. In case of aortic incompetence, the difference between the systolic pressure and the diastolic pressure is higher than normal. So the pulse pressure wouldn't be 40 millimeters mercury as normal, but it might be 60 or 80 millimeters mercury. And this is because during diastole, some of the blood regurgitates or backflows into the left ventricle, resulting in diminution of the diastolic pressure. And this results in a larger volume of blood that will be pumped in the next cardiac cycle by the left ventricle, thus a higher systolic pressure. So when you have a lower diastolic pressure and a higher systolic pressure because of the backflow, this will result in increased pulse pressure or difference between systolic and diastolic blood pressures. The questions on the measurement of the blood pressure would be about the definition of the systolic and diastolic pressure, the definition of the pulse pressure, the values of each, to justify why we measure in the brachial artery and why in the left brachial artery, because the left brachial artery is more towards the heart, because the heart is, it's true that the heart is a central organ in the chest cavity, but its axis is downward and to the left, meaning that the apex of the heart would be closer to, and the left ventricle would be closer to the left brachial artery. Another question is to justify why the patient should put his arm on a table or on a horizontal surface at the same level of the heart, because this would be a better representation of the blood pressure of the patient. Of course, you're frequently asked about this part of the diagram. When the blood pressure, say for example that the patient has a blood pressure that ranges from 80 to that is 80 diastolic and 120 systolic. So below 80, you will hear no sounds. You are frequently asked to justify, because when the pressure in the cuff is below 80, meaning that when the pressure in the cuff is below the diastolic blood pressure, this means that the artery inside, the brachial artery, is fully open, and therefore the blood flow is smooth and laminar, so you hear no sound. You might also be asked to justify why above 120 millimeters mercury, when the pressure in the cuff is above 120 millimeters mercury, you hear no sound, because when the pressure in the cuff is above 120 or above the systolic pressure, this means that the brachial artery inside the arm is totally closed, and therefore there is no blood flow at all, and therefore there are no heart sounds. In between 80 and 120, we hear a sound. Why? Because the blood flow in the brachial artery in such a case is turbulent. Why is it turbulent? Because the artery is partially closed, resulting in a turbulent blood flow, and the sound we hear, or the sounds we hear, actually, because they are intermittent, they appear and disappear, they are interrupted, and these sounds are called Korotkov sounds. Of course, you might be asked about the about the auscultatory gap, meaning that I might tell you that if the systolic pressure of the patient is expected to be around 120, why do we have to raise the pressure in the cuff about 20 to 30 millimeters above 120? This is to avoid missing an auscultatory gap. What is an auscultatory gap? It is um, it is a value of the pressure between the maximum systolic pressure heard and the real systolic pressure. You can find a gap in which you hear no sounds. So it is a gap above the systolic pressure, above, for example, 120, when you hear no sounds. That's why we call it a gap. But why do we have to go above this gap? Because sometimes after having heard the last Korotkov sound at 120, and then you raise the pressure, you hear nothing, but again, you might hear the pressure at the Korotkov sound again at 160, meaning that the systolic pressure is actually 160 and not 120. And this usually occurs in hypertensive patients. So if you get satisfied by having heard the last Korotkov sound at 120 and you do not try to raise above 120 to ensure that there are no more sounds after the auscultatory gap, so you might miss the real value of the systolic blood pressure. Of course, hypertension is elevation of the systemic blood pressure, and it is actually elevation of the systolic and the diastolic blood pressure. Elevation of the systolic blood pressure above 150 and elevation of the diastolic blood pressure above 90 millimeters mercury. The rise in the diastolic pressure or the elevation in the diastolic pressure is more serious than the elevation of the systolic pressure, or the body is more sensitive to such elevations, meaning that a +5 elevation in the diastolic pressure meaning that the diastolic pressure of 95 millimeter mercury might be a serious condition that necessitates hospitalization, whereas the elevation of the systolic pressure from 120 to 150 or even 160 might not be that serious. Justify hypertension is called a silent killer because all the complications of hypertension that might be serious, like cerebral hemorrhage, for example, or a brain stroke, might occur without any symptoms. So silent here means showing no symptoms. What are the symptoms of hypertension? There are common symptoms that occur in all hypertensive patients, unless they are asymptomatic, of course, and these symptoms are usually headache and lightheadedness or dizziness. Actually, tinnitus is one of the symptoms of severe hypertension, in addition, of course, to blurred vision, vomiting, chest pain, retrosternal pain, and arrhythmias. If a hypertensive patient suffers from any of these symptoms, then he should visit a doctor on the spot and his blood pressure should be measured on the spot. The treatment of hypertension is, of course, antihypertensive medication, medications that lower the blood pressure, mainly by diminishing the heart rate and dilating the arterioles or the peripheral circulation. But before or sometimes we might give a diuretic to help the body get rid of excess salt, because extra salt in the body leads to constriction of the arterioles and elevation of the blood pressure. But before doing all this, first of all, we have to reassure the patient. We have to ask the patient to restrict salt in the diet. We have to ask the patient to try to lose weight. we have to give sedation to the patient, especially if we know they are under stress, because sometimes upon taking those general measures like salt restriction, like diminution of weight and sedation, the blood pressure drops automatically without the need for an antihypertensive medication. You might also be asked about the characteristics of blood capillaries. Blood capillaries are very thin-walled. The thickness of their wall is one layer, so they are one layer thick, and they have fenestrations or spaces in between their endothelium to allow for exchange. Being thin, of course, will also allow for diffusion of substances like carbon dioxide and oxygen, not only through the fenestrations, but also through their thin endothelium. So they are thin to allow diffusion of small non-charged molecules. They have fenestrations to allow for exchange. They are the only vessels in the circulatory system that have fenestrations and that are one layer thick. Their walls are one layer thick. They have a large surface area to increase the surface area for exchange. And why do they have such a large surface area? Because they are highly branched around the cells of the body to enable every cell to take in oxygen and nutrients and give out carbon dioxide and waste products of metabolism. The capillaries do not have any elastic fibers or muscle fibers in their walls, and this sounds normal because their walls are made of one layer of endothelium. Of course, you know that the arterioles divide into capillaries and that the capillaries merge into venules, and that all the venules will merge into veins, and that all the veins from the head and neck will merge into the superior vena cava, and all the veins from the lower half of the body will merge into the inferior vena cava. Of course, as you know, we have two types of capillary exchange. We have the alveolo-capillary exchange, which we discussed at the beginning of the videos, and we have the tissue capillary exchange. Of course, this exchange at the capillaries is the reason why the oxygenated blood becomes converted gradually into deoxygenated blood, because at the cells, when the pressure is still high, oxygen and nutrients pass from the capillaries to the cells at the tissues, of course, and on the other hand, we find that after cellular respiration is done by the cells, carbon dioxide and waste return to the capillaries. So the capillaries become gradually loaded with carbon dioxide and the blood becomes gradually deoxygenated. Here, of course, you have the terminal arterioles before the capillary bed, and here you have the terminal or the beginning, the first venules after the capillary bed. Whether it is oxygen diffusing from the blood to the cells or carbon dioxide diffusing from the cells to the blood, they are always diffusing down concentration gradient by simple diffusion. And water, of course, will diffuse down concentration gradient from higher water concentration to lower water concentration by osmosis. Why do we have lymphatics here? We have lymphatics in order to carry the excess fluid that cannot be carried by the veins. Now, here I might ask you about the importance of the valves in the veins and the muscles around the veins. Both allow or ensure forward flow of venous blood towards the heart and prevent backflow of blood. So when do varicose veins? First, what are varicose veins? Varicose veins are engorged tortuous veins like the ones you see here. What is the cause of engorgement of those varicose veins? It is the pooling down of blood by gravity. And what's the cause of this pooling down of blood in the veins? Weak valves along the veins and weak muscles around the veins. Now, normally, how do the internal valves inside the veins, the internal vein valves, prevent backflow of blood? Now, normally, the venous blood is moved upward against gravity, for example, from the lower limbs of the body, from the legs to the heart. And usually, after the blood has passed, the veins close so that if the blood tends to fall downward or pull downward by gravity, it wouldn't be allowed because of the closure of the valves. And this is exactly what happened here. You can see the arrows. The venous blood is trying to pull down by the effect of gravity, but the closed valves prevent it. If the valves are weak, then there will be pulling down of blood against gravity, and there will be varicose veins. What's the role played by the leg muscles or the calf muscles in preventing varicose veins? When these muscles contract, they squeeze up or milk up the venous blood towards the heart. So if you don't use your muscles frequently, if you stand up for a long period of time, then there will be pooling of blood. How can we treat varicose veins? First of all, protection or prophylaxis by using the muscles of the leg efficiently and preventing standing up for long periods of time. But there is another surgical way in severe cases is sclerotherapy. And in sclerotherapy, you inject the wall of the vein with a sclerosant or a chemical that causes complete occlusion or obliteration of the vein to prevent this tortuosity or engorgement of blood and prevent pooling down. Of course, concerning the systemic and pulmonary circulation, I have explained it before. You just have to know where it starts, where it ends. You just have to compare the pressures. Of course, the pulmonary circulation has a lower pressure than the systemic circulation, and you have to control the length of the journey. Of course, the pulmonary circulation is shorter than the systemic circulation. What's the importance of the pulmonary circulation? Loading the blood with oxygen in the lungs and unloading from carbon dioxide. What's the importance of the systemic circulation? Providing oxygen and nutrients to all the tissues of the body and getting rid of carbon dioxide and waste substances. This slide on the bronchial arteries is not included. We've talked a lot before about alveolo-capillary exchange. I might not ask directly about alveolo-capillary exchange, but I might ask you to explain the process that helps oxygenation of blood in the lungs. Or I might ask you to justify why the pulmonary veins have a much higher oxygen level than the pulmonary artery. So in such a case, you should talk about the alveolo-capillary exchange and how it helps loading the blood vessels with oxygen and unloading from carbon dioxide. Concerning the coronary circulation, you should know that it represents the small, very small blood vessels that supply oxygen and nutrients to the heart. You should know the peculiarities of the coronary circulation. The coronary arteries are very small. They are very easily obliterated because they are present under the pericardium, and when there is systole, the The coronary arteries are might be a bit obliterated. They fill mainly during diastole when when the heart is relaxed and when there is no compression on the coronary arteries, and they are end arteries, meaning that they are the only source of oxygenated blood to the myocardium, and they have very few side vessels or very few collaterals. Of course, myocardial infarction is a more serious condition than angina pectoris. Myocardial infarction means that there is complete obliteration of the coronary artery, one or more branches of the coronary artery. If it is the anterior branch of the coronary artery that is occluded or even partially occluded, then the patient will suffer from severe retrosternal pain. If it is the branch that supplies the inferior wall, then the pain would be in the left shoulder and referred to the left arm. Myocardial infarction is associated with severe symptoms like dyspnea, like severe arrhythmias, like pallor of the patient, like sweating, cold sweats. And if it is affecting the inferior wall, not the anterior wall of the heart, it might be associated with symptoms like nausea and vomiting and might be confused with digestive symptoms. So in a patient who has cardiac symptoms like dyspnea and arrhythmia, nausea and vomiting should be taken seriously because they might be the presentation of myocardial infarction. How could we diagnose myocardial infarction? Just like any diagnosis, number one, from the history, number two, from the ECG, where there will be elevation of the ST segment in new infarcts, and elevation of the cardiac enzymes in blood. Why am I saying in new infarcts? Because sometimes, but this we haven't mentioned in class, old infarcts that are seen on the ECG after 6 months, for example, might show a pathological Q wave. It is the Q wave that we know, but it is wider and deeper. So when you have a wider, deeper Q wave, you have to think about a previous attack of myocardial infarction, an old infarct, but this we haven't mentioned in class. How can angina pectoris differ from myocardial infarction? In angina pectoris, we have a relative deficiency of blood and oxygen to the myocardium, whereas in myocardial infarction, we have an absolute deficiency because there is complete occlusion of the artery. In angina pectoris, the relative deficiency means that there is oxygen that reaches the myocardium, but the oxygen supply is less than the oxygen needs. This might be due to a partial obstruction by a clot or due to diminution of the blood flow because, for example, of hypovolemia, or it might even be due to work overload on the heart, meaning that the heart is trying to pump at its maximum rate, but still the volume of blood that reaches is not enough. Of course, angina pectoris is mainly characterized by a depression, a horizontal depression of the ST segment for more than 2 millimeters depth, and at the same time, there is no elevation of the cardiac enzyme and there are no pathological Q waves. Here, for example, you can see the ST segment depression that should be horizontal. Of course, I wouldn't get you a depression like this because it's not horizontal, so it might be confusing to you. And here, this horizontal depression of the ST segment is an indication of angina, whereas the elevation of the ST segment, horizontal elevation, is an indication of myocardial infarction. By this, we would have ended our revision, and I wish you the best of luck tomorrow on your test. Thank you. Bye.